We work very closely with the administrator, with the director of nursing, as well as the member with the family members to coordinate all those benefits, like we were saying, even going and making all their appointments, keeping track of all their care, all their medication management, etc. Okay, so what we have seen when this kind of collaboration goes smoothly is the goal and the track record would show a reduction in hospital admissions, a reduction in the length of stays, and a reduction in polypharmacy. So the IEs really bring added value to the members in terms of the supplemental benefits, because we said they are going to get additional benefits as opposed to being in original Medicare or a straight MA plan. But like we said, a lot of these benefits are really going to be much richer on the D side, on the DSNP side. The way that we design the benefits, our supplemental benefits for our I and our IE, is really to kind of go hand in hand with the benefits, the expanded benefits the members already receiving from the long-term care program. So the I and the IE really tailor the supplemental benefits to the needs of the residents and do not give them anything that is duplicative. So going back to the gentleman's point is we know exactly how to go and spend the dollars. A lot of the other plans are going to be putting the dollars into the supplemental benefits in terms to be able to secure that member and to be able to hook them on like that, right? But that really would not be the best way of spending the revenue that we receive from CMS. So where we go, we really put our dollars is in partnering with the provider, with the nursing home or with the ALF. Okay, so when we're talking about the financial benefits of partnering with an I-SNP or an IE SNP, this is really you guys as nursing homes or ALFs. So when a SNP becomes participating provider with an I-SNP, what happens is you guys are entitled to a set amount, something called a PMPM, a per member per month, in which the nursing home agrees to provide quality care to each of its residents in return for this payment. It's important to note that the I-SNP will only be successful if hospitalizations are effectively managed. So if the nursing home should consider the impact of reduced skilled utilization, it could really impact what you guys are having on that side, and then not be able to work out. So really, whether or not you guys partner with an I-SNP is very dependent, and I'm speaking to nursing homes, on the amount of risk that you're able to take on and the financial stability of that nursing home. So the PMPM payments typically increase during the first year of the resident's medical status as risks are better understood and documented. So when a member first comes on the plan, especially if they come from original Medicare, they will probably not be risked in an optimal way, right? So as that takes place, the revenue to the health plan increases, which then means that the shared dollars to the nursing homes also increase. So we have seen a growth of ACOs and MA plans as we see that CMS is going towards value-based purchasing. We do also see that nursing homes have continued to experience a decline in fee-for-service. Medicare revenue mix in nursing homes across the nation declined from 26 to 21% from 2012 to 2022, while the Medicare Advantage revenue mix increased from 8% to DSNP. I'm sorry, to 10%. So really what we're seeing overall in the market is there really is kind of a going out with the fee-for-service model, and we're coming in to value-based care, to managed care, through the Medicare Advantage plans and through the ACOs. So when we're talking about really the reimbursement that's going to go to the I-SNPs, it really, like I said, depends on the financial risk that you guys are prepared to take and able to take on. So the payments that you guys would be receiving would be either a PMPM, some sort of risk arrangement, or some sort of shared savings. And again, what tier you guys would fall into depends on the negotiations with the health plan and or what you guys are financially able to take on. So what we have seen, back to your question of the track record, and this is pretty much amongst ISNPs nationally, is we've seen a 10 to 15 increase in facility revenue. Obviously, PMPM payments for care coordination, that's not only for nursing homes on the ISNP, but that is also for assisted living facilities on the IE, and opportunities for shared savings. When administered properly, this leads to a 40% reduction in administrative time, a streamlined authorization process, and higher satisfaction scores from the members. Okay, so now we need to talk about